Dear colleagues, welcome to this Ashford Campus workshop. My topic I was asked to present is taking out the ovarian tissue, how and how much. Actually, I thought this is a simple topic, but it is not simple. To take the tissue out is simple, but to decide how much should be taken out is not simple at all. And this presentation gave me the fantastic chance to reflect what I actually did, and I adapted my own attitudes a little bit. So let's see why I'm saying this. First of all, nothing to declare. This is the agenda. We will talk about the techniques of tissue removal, very simple procedure. And then all the other topics are about how much should be taken out. First of all, techniques to remove the tissue. Well, there are two options. We can either take out the whole ovary. This nice picture is from Paris. It is very simple. You just use a stapler or whatsoever. However, no electrocoagulation or not very close to the ovary, the electrocoagulation to not destroy the tissue. Here they use the stapler, which works very easy and nice to take a whole ovary out. If you want to take only 50% of one ovary out, you can do it as I have shown here. That's the way we do it. That's the way how Fertility Protect does it. What we do is we grasp the cortex here with the sharp instrument. We grasp the cortex. Then we use very sharp scissors and we just cut off 50% of the ovarian cortex. Once we are in the middle of the ovary, we re-grasp the ovary. We take it here to the tip of the tissue, and then we finalize the procedure, as you can see here. Okay, and then there's a very important steps which is followed, because when you can see, of course, there is some bleeding, as you can see here, and as more bleeding there is, as more coagulation you might need, as more harm you do to the ovary. So what we do when we took 50% of the cortex off, we just let the ovary drop, because it's only mild bleeding. We just leave it inside the abdomen. We take the tissue out, take our time. It can take a few minutes, don't worry. Take the tissue out, and then you start flushing the abdomen, check everything. And then after a few minutes, you grasp the remaining ovary again. You grasp only once here at the corner, only this little tiny edge which you grasp, not to traumatize the tissue. And then it has been taken 5 minutes for the body to stop, let's say 50% of the bleedings. And if you have only 50% of the bleedings left, it means you have less to coagulate. So the surface needs to be coagulated, but very carefully. We do it with a bipolar diathermy. So we place it on this area where there is some bleeding. We really identify the bleedings, and then we coagulate very, very careful. You have to be careful with coagulation here inside in the middle of the ovary, because the vessels are coming from here. And if you coagulate a large vessel in the middle of the ovary, you might lose substantial amounts of ovarian tissue. So taking out 50% of an ovary is not difficult, but you can make tremendous mistakes. If you coagulate too much, you destroy the tissue which is still in there. So don't coagulate too much. Take your time. There is not much bleeding. Okay, so this is the procedure of taking out the tissue. Here I had prepared a video. The video doesn't work, but it doesn't really matter. It just shows you how you can use these sharp scissors to get off this cap of the ovary. So the next topic is already about how much tissue needs to be taken out, or how much tissue should be taken out, or what is the harm of taking out tissue. I think that's the first very essential question. And what we want to present here is, what is the effect of tissue loss on the onset of menopause? We have two studies published in 2012 and 2014, and both studies are telling us exactly the same. If a unilateral oophorectomy was done, so one ovary is missing, this is associated with an increased risk of premature ovarian failure and earlier menopause. And both studies are exactly saying the same: the menopause starts 1 year earlier. So in a normal setting, a normal woman, no cancer, nothing at all, it's probably it doesn't matter that much to take one ovary out. It doesn't matter that much, yes, because I mean, menopause is more than just the last bleeding, because the premenopausal system and time with this transition with all these symptoms start much earlier if you take one ovary out, but still, it's only 1 year. However, what we do not know, because we're talking in the context of cancer, or we're talking about in the context of fertility preservation, we do not know what is the effect of unilateral oophorectomy on the onset of menopause after gonadotoxic therapy. We have no idea. And we have no idea what is the effect of unilateral semi-oophorectomy. So we take 50% of an ovary out. Unilateral semi-oophorectomy of taking 50% of the ovary out on the onset of menopause. We just don't know. Yes. So that is something, it's kind of a black box, and we don't know if it's better not to take that much out regarding the onset of menopause or not. We just don't know. Well, the question is, does it matter how much tissue we leave? And the next question will be, does it matter how much tissue we freeze? So it's all about leaving and freezing. Let's see if it matters, or if it does matter how much tissue we leave. We have to look at it from 4 perspectives. We have a psychological perspective, we have a safety perspective, we have an endocrinological perspective, and we have a fertility perspective. So from the point of view of the woman who wants to leave her ovaries, we have 4 perspectives to look at. Let's look at the first 2 perspectives, the psychological one and the safety one. Well, the question is, does it psychologically matter to take a whole ovary out or only to take 50% of the ovarian tissue out? Does this make a difference? To be honest, we have no studies, we just don't know. And to be honest, I have no feeling if it matters for the women or it does not matter for the woman. So I turn it around and I ask you, what would you think? Does it matter to be semi-castrated, to lose one gonad, or still to have both gonads, one is smaller than the other? I have no idea what you think. Of course, it's always better to have more gonadal tissue, but of course, it also means if you have more gonadal tissue, you have less in your freezer. So there is a psychological perspective where we don't know how much it matters. There's also a safety perspective. Let's look at this. If the unoperated ovary will be lost, so the ovary which is still inside will be lost due to endometriosis, ovarian tumors, torsion, etc., then there is still the biopsied one, in case you take only 50% out of the tissue of the ovary, is still a biopsied one in case of semi-oophorectomy. So regarding safety for the woman, it might be better to leave 50% of the ovary inside. Just regarding safety. Of course, the risk is not that high to get a torsion. The risk is not that high to get an ovarian tumor from nothing, yes? But for example, if there's endometriosis inside when you take the tissue out, then think about this endometriosis could spread, this endometriosis could grow, it could possibly destruct the still remaining ovary. So regarding safety, this also needs to be taken in consideration. But of course, I have no real clear answer what should be done regarding safety. But what I do note is the endocrinology part. Let's look at the endocrinological perspective. What we do know is that the ovary is an endocrine organ. And what you can see is testosterone, which is a very strong androgen, decreases, the concentration decreases throughout the life of the woman. It drops by about 60–70% from the fertile period to, let's say, about 70. So there is a tremendous decrease of testosterone. And what else we know is that before menopause, yes, the fertility phase, the ovary produces about 25% of the whole testosterone of the woman, only 12%, 25%. However, after menopause, the amount of tissue produced by the ovary is 50%. So the fraction of testosterone increases after menopause, and the ovary becomes more and more important regarding endocrinological function. And we do know that androgens do play a significant role in women's health and well-being. So from the endocrinological perspective, it certainly makes a difference whether you have only one ovary left or you have 1.5 ovaries left. I'm still not saying that you should only take 50% of an ovary out. I just want to tell you things which you possibly never thought about. The ovary matters, even at the age of 60 and 70. Now let's look at the fourth perspective, the fertility perspective. Let's look at two scenarios. The first scenario, the woman wants to get pregnant spontaneously, not with the tissue frozen. She wants to get pregnant spontaneously with her own ovary, what the woman always wants first. If she wants to get pregnant spontaneously, then the biopsied ovary will probably not significantly contribute to the development of the leading follicle. If we have still one normal ovary inside the abdomen and a 50% ovary which is left, and the 50% ovary is probably just lying there quietly, not producing leading follicles, because the main cohort of follicles will come from the large ovary. So in this case, as long as the fallopian tube on the side of the non-operated ovary is functioning, what I always expect, yes. So if the non-operated side is very nice, is very well, then the biopsied ovary does probably not improve fertility because it is not helping to create the dominating follicles. The ovulation will not come from the remaining ovary. However, if the woman requires assisted reproductive technologies like IVF and ICSI, then the biopsied ovary will contribute to the pool of aspirated oocytes, and then the biopsied ovary does probably improve fertility. So, in most cases, the woman wants to get pregnant spontaneously, then the remaining ovary is not helpful. If she wants to get pregnant using ART, the remaining 50% ovary might be helpful. Okay, so these are the four scenarios regarding the amount of tissue left inside the pelvis. The question is, how important is the fertility perspective? I mean, a woman, as I said, there are many perspectives, it's a complex situation, and fertility is only one aspect. What I did here, we provided in the book we published, we collected the studies, we looked at different studies and checked in how many women tissue was actually thought up to be transplanted. And only 3% of cases, 3% of those who froze tissue, the tissue was used for transplantation. Only 3%. This number might go up to 5, maybe even to 10. I don't think it will go further up than 10%. For sperm, for example, the numbers are 8%. So it might go up to the same numbers as for sperm. But let's say it's 5%. It means in 5% of women, the women will have a benefit of having had frozen a tremendous amount of tissue, a high amount of tissue, a whole ovary possibly. But in 95%, the women will have advantages if she still has more tissue or as much tissue as possible inside her abdomen, because the tissue is just not needed. The next question, as I said, it's about leaving or freezing. Does it matter how much tissue we freeze? Of course, it somehow matters. Yes, if you have more tissue to transplant, it does matter. You can have a probably higher chance. That's what we expect. But here we have only one perspective, only the fertility perspective. First of all, let's look at success numbers. Regarding the network Fertility Protect, we have numbers, how many cases, let's say, 50% of the ovary is removed. And as you can see here, published in 2015, the last year of this publication, 2013, 97% of women, only 50% of an ovary was removed, but the remaining ovary was left inside. And looked at more recent registry data, and it's still like that. In most cases, only 50% of the ovarian tissue is removed. And I also looked at the proportion of women having had a total oophorectomy according to the different diseases. And what you can see, interestingly, in breast cancer, the proportion of women in which a whole ovary was taken out is higher than in other diseases. Just keep this in mind. And with this system, taking 25% or 50% of one ovary out, the overall success rate, meaning live birth rate per woman, is 26%. That's a new study which will come out soon. Hopefully soon. We just collecting our data in 200 transplantation is 26%. We have two large data series around regarding success rates. The first one is the one on the top from Shapira et al. And this is a group in which they tried to collect the data from 3 centers which they thought they are very successful to show how successful the whole thing can be. And indeed, they found a live birth rate of 40%, 41%, with rather young women. There's another paper coming out soon. It's in press by Dolmans in fertility and sterility. And here the success rate is 26%, but the women are a little bit older. So the success rate of transplantation of tissue is about 30 to 40%. What we should not forget is that freezing of oocytes and transferring these embryos, the success rate is in women younger than 35, as the other two studies which I showed you, and these ones, the women were also quite young, is about 40%. So regarding the evidence now, we have a little bit higher success rate if you freeze oocyte. That is also something needs to be kept in mind. Of course, however, it matters for the reproductive physician, for the embryologist. It does matter if you have a higher amount of tissue frozen. According to this wonderful slide from, I've forgotten to include the citation, is from Dora Myra. And the question is, of course, if you freeze more tissue, hopefully to increase the amount of the remaining ovarian reserve after transplantation by, let's say, 50%, by 100%, and then having to get a higher success rate. But we do not have any data telling us it is better to have more tissue or it's not better to have more tissue for transplantation. We're just assuming that. There are also a few scenarios which you can draw to think about if it might matter to have a high amount of tissue to be transplanted or a lower amount of tissue to be transplanted. So let's look at the amount of transplanted tissue, what you can expect. If you have a woman who has a POI, so she's not having her own ovarian function anymore, she's not producing follicle. In this case, we have to have a sufficient amount to induce a regular cycle. We know it needs some amount of tissue, but 50% of one ovary is probably enough. We don't know if you can split this amount of tissue to get a regular cycle. It should be enough, however, to get a regular cycle if it transplants the whole tissue of 50% of one ovary. So women who wish to conceive spontaneously after transplantation, it is 2 in 3 women like that, the tissue should be sufficient. Women who want to conceive by assisted reproductive technology after transplantation, then you need a tremendous amount of tissue because you want to have more follicles. It's easier to get more follicles after stimulation. So the higher amount of tissue, the higher number of oocytes. In this case, it might be better to have a high amount of tissue to be transplanted. And there's a certain scenario. Let's look at this. If the female age is increased at the time of freezing of the tissue and at the time of transplantation the same, then the ovaries are still functioning. This is a typical breast cancer situation. The woman freezes tissue, let's say at the age of 35. And then after her endocrine therapy, she's 42. The ovaries are still functioning because the treatment was not that gonadotoxic, but she wants the tissue to be transplanted because she wants to get tissue, want to get younger oocyte from the transplanted tissue. But if the ovaries are still functioning, the transplant needs to override the function of the ovarian function of the ovaries, which are still inside. And then they also need quite a higher amount of tissue to override the remaining ovarian function. So also keep this in mind. So let's come to the last point. Should, following all these thoughts which I presented to you, should the amount of tissue depend on the clinical situation? I tried to draw a conclusion, yes, regarding the amount of tissue to be transplanted, to be frozen, and regarding the clinical situation. First of all, of course, I just want to insert this. The main topic is always not to do any harm, to do something which helps the woman, to help her in all different aspects, not only fertility. So many things needs to be considered. That's, of course, the basis of the whole slide which I'm presenting you now. What does that mean? Whenever you take tissue out, remember, the ovary is more than a follicle-providing organ. It's an endocrine organ, and it has an important function for the woman. as we do not want to do harm, as we want to leave as much tissue inside, but we also want to have a high potential of fertility, one of the solution might be freeze oocytes. If you have enough time, so if possible, go for ovarian stimulation and freeze oocytes. First of all, you can leave tissue inside the pelvis, and the second is the success rate seems to be a little bit higher. However, if there's not enough time available to do ovarian oocyte freezing, then you need to go for ovarian tissue. And what then you should do? First of all, take tissue from the side with a lower chances of spontaneous pregnancy. It is in most cases the left side. Yes, the left side you have a higher risk of get to endometriosis. So this tissue can rather be taken out than from the right side, because if you leave the whole ovary in on the left-hand side, the woman gets endometriosis, you might get a problem. And the left ovary is smaller. There are different studies around showing that the left ovary is smaller, the ovarian reserve of the left side is lower. So it might be an idea always to go for the left side. If the woman has a low risk of PUI, and let's say maybe less than 20%, maybe less than 30%, I think we shouldn't freeze anything at all, not to do harm to the woman, because the tissue will probably never be used. So as I showed you before, so low risk of PUI, don't freeze. If you have an intermediate risk of PUI, then freeze 50% of one ovary, as I demonstrated at the beginning. This might be a good solution for these cases. If you have a higher risk of PUI, let's say PUI risk of more than 50%, then freeze a total ovary. I think that's something which is quite obvious. And then there's a very special situation, breast cancer. And you remember the slide which I showed you, that in breast cancer, the proportion of women in which a whole ovary is taken out is higher. The thing is, if you have a breast cancer woman, let's say at the age of around 35, 36, 37 maybe, and you freeze tissue because you don't have the time, like in neoadjuvant chemotherapies, to do an ovarian stimulation. And if this woman, especially if this woman is receptor positive, then it will take many years until the woman can get pregnant spontaneously, because she first has to finish her endocrine therapy. She shouldn't stop the endocrine therapy too early. And this means that she will be about 41, 42 years of age. And in these cases, you need a sufficient amount of tissue for the transplantation to override the remaining function of her ovaries, which are still working. So, dear colleagues, I created this suggestion how to go on regarding the amount of tissue to remove. I think there's no solution to say take one ovary out. There's no solution to take 50% of an ovary out. I think we should possibly adapt the amount of tissue to be frozen to the clinical situation. And as I showed you a few slides, so I just want to show you the book from which is taken. So this is a practical fertility preservation book, which you can use for all these kinds of fertility preservation techniques. Thank you very much.